was just a testimony to Thomas's brilliance in putting me at third here, fourth in the speaker list, because it really builds on everything we just heard. So I want to thank Thomas and Yale for inviting me. The question really is, I'm going to focus on infectious diseases because that's kind of what I do. And this is a question that comes up at every level in every government. And this was a question that was proposed by the House of Lords several years ago, where they asked several people to come and give testimony to answer the question, is there a crisis of global dimension in infectious diseases? Or are we just sort of worried about nothing in particular? So this was an ad hoc committee of intergovernmental organizations formed by the House of Lords. And my answer was quite simple, based on real data. So there really is a global burden of a crisis in infectious disease. It accounts for 22% of all deaths and 20% of all disability-adjusted life years, but there's a real discrepancy, there's a real disparity in the developing world compared to the developed world. Where in the developing world it accounts for 52% of all deaths and 50% of the disability-adjusted life years, and it is quite disparate around the world. In fact, if you look at some older data, this is the ratio of numbers of deaths from cardiovascular diseases to infectious diseases. So back in the developed world, back in 1970, about 4 times the number of people died of cardiovascular deaths than infectious diseases. As we go out to 2015, it will be about 8. 8 times more people will die of cardiovascular diseases than infectious diseases. And of course, that could mean that we're all eating worse, but we're all protected against infectious diseases, so it's a ratio. But look at the developing countries. Back in 1970, it was 0.4. So 4 out of 10 people were dying of cardiovascular diseases compared to infectious diseases. Infectious disease disproportionately affected the developing world. But look out in 2015, we're only up to about two times the number of people dying from cardiovascular deaths compared to infectious disease deaths. Not even where we were back in 1970. So there is still this remarkable discrepancy between how people are dying in the developing world compared to the developed world. And so why is that? And there's all the reasons that we just heard, but this is from, I think, the same data that Steve showed. This is the World Economic Forum. If you look at the global risk categories that they define, this isn't even my slide, they define 5 global risks. Environmental risks, look at number 3, and this is not any particular order. Antibiotic-resistant bacteria. We have now a plague of antibiotic-resistant bacteria. In my hospital, at the University of Pennsylvania, and at your Yale New Haven hospital, and every other hospital in the world, you have a very good chance of getting into the hospital and dying of an infection for which I have virtually no antibiotics, because Big Pharma is out of the game of making new antibiotics. So antibiotic-resistant bacteria. Technologic risks. Number 2, unintended consequences of new life science technology. We have the ability now to create de novo, using synthetic biology, some very, very nasty bugs, very, very nasty infectious agents. And that's another talk that I'm happy to give you. But we can use synthetic biology to make influenza that's now spreadable more readily from human to human. Societal risks. We already heard that vulnerability to pandemics. I wrote a paper for OECD a few years ago. There's about $800 billion at risk if there was even a moderate avian flu pandemic in this country. So economic risks, chronic labor market imbalances. If there is a pandemic, you will find the labor markets completely disrupted. And finally, geopolitical risks, widespread illicit trade, including, as Thomas just said, counterfeit drugs. Counterfeit drugs is a major, major problem in terms of infectious diseases. If you want to take a malaria pill, the chances are in the developing world you're taking nothing more than either half diluted or even a sugar pill. So out of the global risks, every one of them has an infectious disease component. And why is that? Well, here's Steve's slide. In the middle of all of this is global governance failure. He just gave a whole talk on that, so I won't talk about it. But it is one of the central issues confronting our community, our global community, in controlling infectious diseases. So, and everybody talks about this. This was something that Tony Fauci, the head of the NIAID at the NIH, said when the whole notion of doing synthetic biology to look at avian flu. Most of us are unequivocal about the value of the research, but deciding what to do with these types of studies is complicated. At the moment, there are no official governing bodies to regulate such decisions. Should we be doing experiments of dual use of concern. They rely on the goodwill of the researcher. So even at the very fundamental level of basic science, there's no governing body. And so my answer to the House of Lords a few years ago was that it's not an exaggeration to speak of a crisis. On the contrary, and I try to include everybody, moral, medical, economic, political imperative to talk about this at the highest level of government. So rather than just talk about it, what are we going to do about it? So, I'm a physician, I'm a researcher, we got to do something. We can't just sit by and do it. So what do we do as an academic? Well, we write a paper. So we wrote a paper with my colleague in India, Cam Rao, and we proposed an international governance system for infectious diseases. And we were very worried about the words that we were using. My legal colleagues counseled me to avoid the word treaty. They counseled me to avoid the word compact. So at first we were using the word international compact. Now we're calling it a global governance system. But really, between us and the rest of the world who's listening, we're really talking about a treaty. But we can talk about the difficulties of thinking about international treaties in a moment. So we said there are ways to solve this problem and actually do it. And so we've talked about this in every number of possible venues, including The Hague. And I'll get back to The Hague in a moment, because the question is, where does this live? And Steve really referred to that. Should it live at the World Health Organization? Should it live in The Hague? Should it live in my university, in your university? Where this compact, this treaty, this global governance system lives is really important if it's going to get done. So what is our proposal for a global governance system? Well, it's really very interdependent, and you've heard a lot of these stories in the first three talks. We really think that a really effective global governance system has to be composed of four basic building blocks. We need more basic and translational science. We definitely need better distribution, equitable distribution of drugs and vaccines, something that Thomas just talked about. We definitely need knowledge sharing in a centralized database. And of course, we need best laboratory practices that include ethical and moral implications of how we do our science. And if we know more in the green box, then we'll know what kinds of science we need to do in the yellow box. If we know what kinds of science and we have translational science in the yellow box, we will have more drugs and vaccines to distribute. If we have more vaccines and drugs to distribute, we better have the right kinds of systems in place. Best laboratory practices. I was on a Department of Defense committee once, and we were talking about security in biological agents, and they showed us a biological lab in the former Soviet Union. Do you know what the security was? It was a string wrapped around a refrigerator with a piece of gum holding the string in place. That was the level of security. It makes you very, very nervous. Anybody could have walked in and taken out whatever they wanted out of that refrigerator. So these are all interdependent. You can't solve the global governance structure without solving each one of these boxes, without really confronting the issues. And there are legal issues, there are political issues, there are scientific issues, there's manufacturing issues. But individually, that won't solve the problem. But we want to solve the problem. In my own lab, we're actually working on making new drugs for tuberculosis. It's something that we're very involved in, and I am absolutely thrilled that Thomas has pushed and pushed and pushed, and we finally have this bedaquiline pilot up and running. But let's take just one of those boxes and see how we might be able to solve it. How do we get equitable distribution of drugs and vaccines? Can we even solve that one box, one at a time? Well, what's one of the problems in terms of distributing vaccines in particular? Well, there are a lot of life-saving vaccines that are available. But guess how many kids die of vaccine-preventable deaths? Anybody want to take a guess? I'll give you a multiple choice. 100,000, 500,000, 1 million, or 2.5 million? What do you think the answer is? 2.5 million, maybe more, kids die of vaccine-preventable deaths. You take your kid to the pediatrician, she walks into the other room, pulls it out of the refrigerator, sticks the kids in the polio vaccine, no problem, or whatever. 2.5 million kids around the world don't have that luxury. And why is that? Because there's no refrigerator next door, because there's nothing to plug the refrigerator into. Most of the world lives off the grid. There are no refrigeration systems, and that's called the cold chain. So we're losing kids to pneumonia, to rotavirus, to measles, simple diseases that we've protected against for generations. And so what is the problem? It's the cold chain. The cold chain means you've got to keep that vaccine between 2 and 8 degrees Celsius. If it heats up, it degrades. If it freezes and thaws, and you smack the thing against an ice pack and it freezes, then when it thaws out, it becomes inactive. And so that's how people get their vaccines delivered to their local health clinic on the back of a camel, on the back of a motorcycle, in solar panels, in ice packs. And guess what? As you go away from the central storage place right at the capital in Kenya, in Zimbabwe, the cold chain degrades. Kids get, either they don't get the vaccine at all, or they get an inactivated vaccine. And this has been well studied. So here's the cold chain, the vaccine manufacturer that we just heard about. It goes to the national airport, and that's pretty good because that's on the grid. It goes to a primary or an intermediate vac storage place, and that's pretty good too. There's some reliable electricity. You get out into the health centers, the health posts, and finally to the kid and the mother, it's inactivated, and that's where the cold chain breaks down. And we know a lot about the specifications of how these vaccines have to be kept. The World Health Organization have refrigerators that are certified. This is the vaccine kind of refrigerator. But it takes energy to power up that refrigerator. And there's no energy in the developing world. There's this whole notion of energy poverty, which is something that we're probably going to talk about. So how do you solve the problem, right? There's no energy but that's just not true. Who has a cell phone in this room? Everybody. There are more cell phones in the world than there are toilet bowls. There are more cell phones than there are toothbrushes. How do you think cell phones work? By magic? They work by electrical power. Every cell company has a tower. Who's been overseas and hasn't had cell phone coverage? Nobody. If there's a cell phone coverage, there's a mobile phone tower. If there's a mobile phone tower, there's power. It is their complete business model to keep the energy on. And so, what's our solution? We wrote a paper. No, but actually we did more. A few years ago, a student of mine, Alice Conant, and I wrote a paper saying, we can solve this cold chain problem by just plugging the darn refrigerator into the base of the cell tower. The cell towers are sometimes on the grid. They always have diesel backup. Now they're having solar and wind backup. The mobile phone industry would collapse if they didn't keep the energy on. It is totally the private sector's incentive to keep that power on. And so we just said, take a look at that picture, and I'll show you why in a minute. Said, plug the darn refrigerator into the base of the cell tower. It costs you 60 cents a day to run a refrigerator. We made that calculation. The cell phone industry is growing leaps and bounds in the developing world. In the dark bars, you see it's really almost exponential. In the developed world, it's almost, it's steady state. But in the developing world, it is exploding. Africa, Asia, South America. The entire world will have coverage by cell phones in a very short time, if not already. So the solution is actually scalable and sustainable. The solution of plugging these refrigerators into a cell tower power source is scalable and sustainable. Too many kids die. We put together a group called Energize the Chain. I forgot who coined that. It's a great phrase though. The mission is, the premise is 2 million kids die. It's because in large part the cold chain has failed. The grid power is unreliable, but the cell tower industry, the private sector here, is the one that's going to help us solve the problem. So the insight was co-locate the refrigeration systems with the cell towers. It's sustainable, it's scalable, it's reasonably environmentally sound, and it's locally owned. And so we thought this had really all of the components of a successful program. And in fact, last summer, not this summer, there was another paper in the New Scientist where they actually went out and looked at what we've done in Zimbabwe, and they very generously wrote a paper, Tower Power Saves Lives. And this is why. Remember, this was the picture, the cartoon in 2010. That's actually what it looks like. That's a tower in Zimbabwe with the vaccine shelter built within the footprint of the cell tower. And it says, Energize the Chain, vaccine shelter. And I don't have to say a word, but this is really, let's see if I can make this thing work now. This says it all. In a 1 minute. Can you hear that?
Life was not always like this. We were losing a lot of babies. A simple vaccine was all that was needed to save their young lives. But the vaccines needed to be kept cold from 2 to 8 degrees Celsius against our African heat. We had to throw away lots of these, and it was such a challenge. Then Econet, through its Energize the Chain program, installed close proximity refrigerated containers. These simply use the excess power from the wireless base stations. Now, we don't have to worry about that anymore.
By creating innovative solutions, EcoNet Wireless is promoting community transformation and joins the fight against the top 5 child killer diseases. EcoNet Wireless, inspired to change your world.
So that was actually sent to me by by a friend in South Africa. That was a public service announcement in South Africa. I didn't even know they did this. So we partnered with EcoNet, which is the largest cell phone operator in Zimbabwe, run by a very visionary guy named Strive Masiawa, and his chief engineer, Bernard Fernandez. I gave this talk in Mombasa, and he said, I'm going to do this. So he went back to his colleagues in EcoNet in Zimbabwe and said, you guys, you engineers, figure this out. And within a year, they designed the vaccine shelters, they plugged them into their cell towers, and now we have about 40 of them up and running in Zimbabwe. We had, Alice went to India last summer, where in collaboration with Indus Towers and the Rockefeller, we're going to start going in Karnataka State in collaboration with Karuna Trust, which is a sort of an NGO that runs a lot of health clinics. We're talking to folks in Uganda, in Nigeria, and in parts of South America. This is basically, in my mind, the problem is solved. This is a no-brainer. We just got to make the connections between the private sector and the public sector, and they're off and running. We really are, we're not, you know, Zimbabwe is Zimbabwe. We had a meeting at UNICEF in June, and Bernard Fernandez came, and he had his laptop. The cell tower has total connectivity. So he said, look at this. And he plugged a map of Zimbabwe up, and all of his cell towers were there. He clicked on a cell tower. He clicked on the vaccine refrigerator, and he said, oh, look, this refrigerator was just open for about 5 minutes. The nurse must have been taking out a vaccine. Real-time monitoring of the vaccine refrigerator. And now we're thinking about real-time inventory control as well, because the last thing you want to do is have one of those folks carry out all the vaccines that are not necessary because they haven't used them all, or they forgot to bring along the pneumococcal vaccine. So real-time inventory, real-time monitoring, health impact, something that Thomas has really been talking about. So, you know, we think this problem is just about solved. Of course, the human relations part is the hard part, but it's getting done. So this is the complicated map. This is Steve's global governance solution, right? But as he mentioned, where the heck does it live? Should it live in the World Health Organization? Should it live at The Hague? Should it live at my esteemed university? Should it belong to the World Economic Forum? Where does this governance system work best? I think you heard that it's probably not going to work best at the World Health Organization, but maybe. And so we think that my university, Yale, Harvard, probably doesn't have the global scope to have this done properly, although it would be great if we did. OECD and the Economic Forum, G20, that's the rich man's group with probably don't really care all that much about it. The UN in the middle is still a possibility. So in order to really make this happen, we're having long conversations with the Institute for Global Justice at The Hague, and they're showing interest. I met with them a couple of weeks ago in Philadelphia. So this may still live at The Hague, and we're pursuing that very intensively with Seamus and a bunch of Thomas's buddies over there. But in the meantime, several years ago, we applied for a special consultative status at the UN, which is really the NGO world, the civil society at the UN. And after a very painful vetting process, last August, we received special consultative status. So next week, I'm actually going up to speak to Andrei Abramov, who runs the NGO section up there, where we're going to take this on as our major project with the UN. We want to go to the UN, and I invite all of you to be our partners in this. This is not just me. I have to run my lab and see patients. I invite all of you to be part of this. We're going to go to the UN next week. We're going to talk to Andrei about how do we set up meetings and be part of the Millennium Development Goal Project, and we have our own project to really get this global governance system up and running. It means that we have this ability to do these things at the UN now. I don't know if it's the right place to live. Maybe it should live in The Hague. Maybe it should live here in Harkness Hall in this beautiful environment. But we have to start somewhere. We've got to solve this problem. We can't just talk about it anymore. We have to do it in our own labs. We have to do it in our own academic professions. We have to do it in our own professional professions. And so that's really where we are. I think we're making some real progress in the last year. And I think with all of your help, and I really mean this as a call to action, they're all the right people here, the economists, the lawyers, the social scientists. There are a couple of doctors in the room even, maybe. So I think we have an ability to solve this problem, and it's something we should take on as a generational imperative, like I told the House of Lords. Thank you.